Coronavirus disease 2019, COVID-19, is a contagious disease caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. The first case was identified in Wuhan, China, in December 2019. The disease has since spread worldwide, leading to an ongoing pandemic. Symptoms of COVID-19 are variable, but often include fever, cough, fatigue, breathing difficulties, and loss of smell and taste. Symptoms begin 1 to 14 days after exposure to the virus. Of those people who develop noticeable symptoms, most, 81%, develop mild to moderate symptoms, up to mild pneumonia, while 14% develop severe symptoms, dyspnea, hypoxia, or more than 50% lung involvement on imaging, and 5% suffer critical symptoms, respiratory failure, shock, or multi-organ dysfunction. Older people are more likely to have severe symptoms. At least a third of the people who are infected with the virus remain asymptomatic and do not develop noticeable symptoms at any point in time, but they still can spread the disease. Around 20% of those people will remain asymptomatic throughout infection, and the rest will develop symptoms later on, becoming pre-symptomatic rather than asymptomatic and therefore having a higher risk of transmitting the virus to others. Some people continue to experience a range of effects, known as long COVID, for months after recovery, and damage to organs has been observed. Multi-year studies are underway to further investigate the long-term effects of the disease. The virus that causes COVID-19 spreads mainly when an infected person is in close contact with another person. Small droplets and aerosols containing the virus can spread from an infected person's nose and mouth as they breathe, cough, sneeze, sing, or speak. Other people are infected if the virus gets into their mouth, nose, or eyes. The virus may also spread via contaminated surfaces, although this is not thought to be the main route of transmission. The exact route of transmission is rarely proven conclusively, but infection mainly happens when people are near each other for long enough. People who are infected can transmit the virus to another person up to 2 days before they themselves show symptoms, as can people who do not experience symptoms. People remain infectious for up to 10 days after the onset of symptoms in moderate cases and up to 20 days in severe cases. Several testing methods have been developed to diagnose the disease. The standard diagnostic method is by detection of the virus's nucleic acid by real-time reverse transcription polymerase chain reaction, RRT-PCR, transcription-mediated amplification, TMA, or by reverse transcription loop-mediated isothermal amplification, RT-LAMP, from a nasopharyngeal swab. Preventive measures include physical or social distancing, quarantining, ventilation of indoor spaces, covering coughs and sneezes, hand washing, and keeping unwashed hands away from the face. The use of face masks or coverings has been recommended in public settings to minimize the risk of transmissions. Several vaccines have been developed and several countries have initiated mass vaccination campaigns. Although work is underway to develop drugs that inhibit the virus, the primary treatment is currently symptomatic. Management involves the treatment of symptoms, supportive care, isolation, and experimental measures. Symptoms of COVID-19 are variable, ranging from mild symptoms to severe illness. Common symptoms include headache, loss of smell and taste, nasal congestion and rhinorrhea, cough, muscle pain, sore throat, fever, diarrhea, and breathing difficulties. People with the same infection may have different symptoms, and the symptoms may change over time. 3 common clusters of symptoms have been identified: 1 respiratory symptom cluster with cough, sputum, shortness of breath, and fever, a musculoskeletal symptom cluster with muscle and joint pain, headache, and fatigue, a cluster of digestive symptoms with abdominal pain, vomiting, and diarrhea. In people without prior ear, nose, and throat disorders, loss of taste combined with loss of smell is associated with COVID-19. Most people, 81%, develop mild to moderate symptoms, up to mild pneumonia, while 14% develop severe symptoms, dyspnea, hypoxia, or more than 50% lung involvement on imaging, and 5% of patients suffer critical symptoms, respiratory failure, shock, or multi-organ dysfunction. At least a third of the people who are infected with the virus do not develop noticeable symptoms at any point in time. These asymptomatic carriers tend not to get tested and can spread the disease. Other infected people will develop symptoms later, called pre-symptomatic, or have very mild symptoms and can also spread the virus. As is common with infections, there is a delay between the moment a person first becomes infected and the appearance of the first symptoms. The median delay for COVID-19 is 4 to 5 days. Most symptomatic people experience symptoms within 2 to 7 days after exposure, and almost all will experience at least one symptom within 12 days. Most people recover from the acute phase of the disease. However, some people continue to experience a range of effects for months after recovery, named long COVID, and damage to organs has been observed. Multi-year studies are underway to further investigate the long-term effects of the disease. Cause: COVID-19 is caused by infection with the severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, virus strain. Transmission of COVID-19. Coronavirus disease 2019, COVID-19, spreads from person to person mainly through the respiratory route after an infected person coughs, sneezes, sings, talks or breathes. A new infection occurs when virus-containing particles exhaled by an infected person, either respiratory droplets or aerosols, get into the mouth, nose, or eyes of other people who are in close contact with the infected person. During human-to-human transmission, an average 1,000 infectious SARS-CoV-2 virions are thought to initiate a new infection. The closer people interact, and the longer they interact, the more likely they are to transmit COVID-19. Closer distances can involve larger droplets, which fall to the ground, and aerosols, whereas longer distances only involve aerosols. Larger droplets can also turn into aerosols, known as droplet nuclei, through evaporation. The relative importance of the larger droplets and the aerosols is not clear as of November 2020, however, the virus is not known to spread between rooms over long distances such as through air ducts. Airborne transmission is able to particularly occur indoors, in high-risk locations such as restaurants, choirs, gyms, nightclubs, offices, and religious venues, often when they are crowded or less ventilated. It also occurs in healthcare settings, often when aerosol-generating medical procedures are performed on COVID-19 patients. Although it is considered possible, there is no direct evidence of the virus being transmitted by skin-to-skin contact. A person could get COVID-19 indirectly by touching a contaminated surface or object before touching their own mouth, nose, or eyes, though this is not thought to be the main way the virus spreads. The virus is not known to spread through feces, urine, breast milk, food, wastewater, drink. The virus also affects gastrointestinal organs as ACE2 is abundantly expressed in the glandular cells of gastric, duodenal and rectal epithelium as well as endothelial cells and enterocytes of the small intestine. The virus can cause acute myocardial injury and chronic damage to the cardiovascular system. An acute cardiac injury was found in 12% of infected people admitted to the hospital in Wuhan, China, and is more frequent in severe disease. Rates of cardiovascular symptoms are high, owing to the systemic inflammatory response and immune system disorders during disease progression, but acute myocardial injuries may also be related to ACE2 receptors in the heart. ACE2 receptors are highly expressed in the heart and are involved in heart function. A high incidence of thrombosis and venous thromboembolism have been found people transferred to intensive care unit, ICU, with COVID-19 infections, and may be related to poor prognosis. Blood vessel dysfunction and clot formation, as suggested by high D-dimer levels caused by blood clots, are thought to play a significant role in mortality. Incidences of clots leading to pulmonary embolisms, and ischemic events within the brain have been noted as complications leading to death in people infected with SARS-CoV-2. Infection appears to set off a chain of vasoconstrictive responses within the body. Constriction of blood vessels within the pulmonary circulation has also been posited as a mechanism in which oxygenation decreases alongside the presentation of viral pneumonia. Furthermore, microvascular blood vessel damage has been reported in a small number of tissue samples of the brains, without detected SARS-CoV-2 and the olfactory bulbs from those who have died from COVID-19. Another common cause of death is complications related to the kidneys. Early reports show that up to 30% of hospitalized patients both in China and in New York have experienced some injury to the kidneys, including some persons with no previous kidney problems. Autopsies of people who died of COVID-19 have found diffuse alveolar damage, and lymphocyte-containing inflammatory infiltrates within the lung. Immunopathology. Key components of the adaptive immune response to SARS-CoV-2. Although SARS-CoV-2 has a tropism for ACE2 expressing epithelial cells of the respiratory tract, people with severe COVID-19 have symptoms of systemic hyperinflammation. Clinical laboratory findings of elevated IL-2, IL-7, IL-6 granulocyte macrophage colony stimulating factor, GM-CSF, interferon gamma-inducible protein 10, IP10, monocyte chemotrectant protein 1, MCP1, macrophage inflammatory protein 1 alpha, MIP1 alpha, and tumor necrosis factor alpha, TNF alpha, indicative of cytokine release syndrome, CRS, suggest an underlying immunopathology. Additionally, people with COVID-19 and acute respiratory distress syndrome, ARDS, have classical serum biomarkers of CRS, including elevated C-reactive protein, CRP, lactate dehydrogenase, LDH, D-dimer, and ferritin. Systemic inflammation results in vasodilation, allowing inflammatory lymphocytic and monocytic infiltration of the lung and the heart. In particular, pathogenic GM-CSF secreting T cells were shown to correlate with the recruitment of inflammatory IL-6 secreting monocytes and severe lung pathology in people with COVID-19. Lymphocytic infiltrates have also been reported at autopsy. Viral and host factors. Virus proteins. The association between SARS-CoV-2 and the renin-angiotensin-aldosterone system, RAS. Multiple viral and host factors affect the pathogenesis of the virus. The S protein, otherwise known as the spike protein, is the viral component that attaches to the host receptor via the ACE2 receptors. It includes two subunits, S1 and S2. S1 determines the virus host range and cellular tropism via the receptor binding domain. S2 mediates the membrane fusion of the virus to its potential cell host via the H1 and HR2, which are heptid repeat regions. Studies have shown that